Hello, Peter Ward here. We're going to be talking about the cranial nerves today. You'll notice I'm standing in front of a whiteboard instead of drawing on a piece of paper because my laboratory space is currently under construction and this is the best option we have available. So, to start with the cranial nerves, we're going to do things a little unusually and we're going to go out of order. We're going to start with cranial nerve number 5, mostly because cranial nerve 5 includes a lot of the modalities that are going to be referenced in subsequent cranial nerves, and so it's a good place to start, and it also serves as a little bit of a conduit by which other axons reach their targets, especially the parasympathetics of the head and neck. So let's get started by talking about cranial nerve number 5, and cranial nerve number 5 is the trigeminal nerve. Now, it's going to be mostly general somatic afferent, meaning it's carrying fibers that we're aware of the senses that are being mediated by that. So if I get my face touched in any basic area, the trigeminal nerve is mediating that general somatic afferent or sensory input that I receive. Now the trigeminal nerve, we're going to start with it and go back to the brainstem a little bit later. Comes out of the pons as a large structure, enters the dura mater where the trigeminal ganglion exists, and that's where the cell bodies, the pseudounipolar cell bodies, are for this nerve, and it immediately branches into 3 trunks that head on out to various parts of the body. The first one is referred to as V1, V for 5, 1 for 1, and is the ophthalmic. I always forget that H. V2, the second branch, is the maxillary nerve, or the maxillary branch of the trigeminal, and the last one is V3, the mandibular. And as these exit the skull, they go through specific structures along the way that are characteristic. And we'll fill these in as we go into each one of these branches individually. But just for reference right now, the ophthalmic nerve exits through the superior orbital fissure. The maxillary nerve exits through the foramen rotundum. And the mandibular nerve exits through the foramen ovale. And we'll discuss those again in a moment. One thing I want you to recognize before we go any further is because these are sensory nerves, the input is coming from the periphery, where there's a little receptor in the skin, follows the nerve back, and when it gets to this ganglion, the axon is connected to a cell body located in the trigeminal ganglion, but it does not synapse there. Instead, the extension of that axon towards the central nervous system is what actually takes the impulse to a place in the medulla or the pons or the midbrain where we can actually become aware of it and have our body respond to it. Just be aware, these sensory axons, these GSA nerves, have an axon that stretches back to the ganglion and then continues onto the central nervous system with the cell body in the trigeminal ganglion able to maintain it and keep it stocked with neurotransmitters and so forth. Alright, so the next thing we're going to do is go into an example or an investigation of the ophthalmic branch of the trigeminal nerve in more detail. Alright, so let's take a closer look now at the branches of V1, the ophthalmic nerve. So, extending off of the trigeminal ganglion, V1 is going to travel through a dural venous sinus. And that sinus is known as the cavernous sinus, and this is a place where sometimes it can become somewhat complicated if a thrombus lodges in this venous cavernous sinus. So this is structure that travels through there. Along with V1, you also have the oculomotor, the trochlear, and the abducens nerve traveling through the cavernous sinus, and maybe a little bit of V2 for variable length. Once those structures have exited the cavernous sinus, they travel through a cleft in the bone to enter the orbit, and that is the superior orbital fissure. Now, once it goes through there, just as the trigeminal nerve split into three, the ophthalmic nerve splits into three major branches. The one that's most visible on the surface of the orbit is the middle one. And this guy is known as the frontal nerve. And it travels just underneath the periorbita inside the orbit. It's usually pretty visible. It travels across and is actually going to innervate the skin of the forehead by going across the orbit completely, splitting into a branch that goes just medial to the nose, right here, and a branch that goes onto the rest of the forehead a little more laterally. And these guys are called the supratrochlear and the supraorbital nerve. Now the supraorbital nerve goes across and loops across this part of the frontal bone as it goes onto the forehead. And as it does so, it passes what's referred to as the supraorbital foramen, if it's a complete hole, or the supraorbital notch. The supratrochlear nerve just runs onto the medial aspect of the forehead near the nose, just right about here. Now that's it for the frontal nerve, but we're going to come back with these two now. The next one along, I'll actually skip down to this guy, is the one that's the most lateral in the orbit. It's going to the lateral side, and the skin around the lateral forehead here, and this is called the lacrimal nerve. The lacrimal nerve supplies the skin near the lacrimal gland, but is in itself not responsible for the lacrimal gland secretion. It's traveling towards the skin through the lateral part of the orbit, and it does indeed wind up near the lacrimal gland out here. But parasympathetic fibers from cranial nerve 7 would actually innervate the lacrimal gland, and the way they get there is that we're going to jump ahead a little bit and draw in a little branch of V2 traveling near this area. And again, we'll get to this in a moment, but this branch of V2, the maxillary division of the trigeminal nerve, is called the zygomatico temporal nerve. Running out of room. On this are some fibers that were coming from the tergopalatine ganglion. Again, don't worry, we'll talk about that in a moment if you haven't seen my autonomic video already. And these postsynaptic parasympathetics jump off the zygomaticotemporal to reach the lacrimal nerve, and thereafter travel to the lacrimal gland. And these are the fibers that actually allow it to secrete tears. And if I had damage to my orbit somewhere back here that wiped out my lacrimal nerve, I would still be able to secrete tears because these fibers jump on a little bit later, whereas damage a little more distally would wipe out the ability to make tears and keep the eye moist, as well as a bit of sensation on the lateral side of the orbit. Alright, now next up is a branch that has several daughter branches coming off of it. This is going to be the nasociliary nerve. Now the nasociliary nerve basically tells you what it does. Naso means nasal cavity, and ciliary refers to the globe of the eye. It's innervating the eye and is sensory to the sclera and the cornea. The fibers that do that are referred to as ciliary nerves. We're going to draw in here some long ciliary nerves. There's actually multiple long ciliary nerves, but we're only going to draw one for right now. And I'm actually lying a little bit. We'll draw another in, but we're going to leave it unnamed for the moment, going to the same target, going to the eye. Now let's go back to some other sensory branches and put the naso and nasociliary. The nasociliary gives off a branch to the ethmoid bone and the air cells there, does the same thing again, and then continues with a terminal branch that's going to innervate the skin just around the nasal area on the lateral aspect of the nose, medial canthus of the eye. These guys are named pretty sensibly the posterior ethmoidal nerve. No big surprise, this one's called the anterior ethmoidal nerve. And this one we had out here on the eyelid, supratrochlear nerve. This terminal branch is going to be referred to as the infratrochlear nerve. And the trochlea is a structure that's associated with cranial nerve 4 and the muscle that innervates the superior oblique. We'll talk more about that later. Right now, let's jump back to this guy that I left unnamed. The reason that one's unnamed is because there's a collection of parasympathetic cell bodies hanging out in the orbit, and it gloms onto some of these branches of the ophthalmic nerve. And one thing to know about postsynaptic parasympathetic nerves is that they always get where they're going by jumping on a branch of the trigeminal. So even though cranial nerves 3, 7, and 9, 3, 7, 9, and 10 contain presynaptic parasympathetics, the postsynaptic parasympathetics for 3, 7, and 9 all get where they're going by jumping on trigeminal branches. In this case, we've got the nearby motor oculomotor nerve, and it's going to muscles of the eye. It's cranial nerve number 3. And along with it, coming from the Edinger-Westphal nucleus in the brainstem, we've got parasympathetic fibers, presynaptic parasympathetics that enter the orbit, and once inside the orbit, they jump off of the oculomotor, jump onto this ganglion, and they get to where they're going, synapse in this parasympathetic ganglion in the orbit. It's called the ciliary ganglion. And thereafter, postsynaptic parasympathetics go to the eye by following these additional branches of the nasociliary. And these guys are now known as short ciliaries that are coming from the ciliary ganglion. Now that's all good, except if you've seen the autonomics talk, you know these parasympathetics don't go to the eye itself. They're going to some smooth muscle bundles of the iris and the lens called the ciliary body. And I've described those in a lot more detail and done a lot more talk of their function in the autonomics of the head and neck video, so we're going to skip that for right now, just to mention that the pupillary constrictor muscle and the ciliary body receive their innervation from oculomotor presynaptic parasympathetics synapsing in the ciliary ganglion, and then postsynaptic parasympathetics from the ciliary ganglion follow short ciliaries to the eye to innervate these structures. Everything else going on in green is sensory, and that's the trigeminal nerve's major function. And we'll go talk about its next branch, the maxillary, in the next section. Alright, and we're back. Now we're going to talk about the next branch of the trigeminal. We've already discussed the first branch, the ophthalmic, V1. Now we're going to move on to the next one, the maxillary. Now the maxillary nerve continues through the dura until it exits through a foramen. Move a little further along here. known as the foramen rotundum. Now from there, it's going to head into a space called the trigopalatine fossa, and here it just goes nuts. First thing it's going to do is send off two branches that head down to the palate. And the one that goes anterior innervates the mucosa lining the hard palate. And then there's going to be the greater palatine nerve. No big surprise, the one that goes posterior to innervate the mucosa and the covering of the soft palate is the lesser palatine nerve. Next up, there's going to be some branches that go to the side of the forehead. We actually saw these in the last little section. They're going to go to the outside area of the orbit along the zygomatic bone, and because of that, they're referred to as the zygomatic branches. And one of them is the zygomatico-temporal that we just saw last time. Zygomatico-temporal. And the one that's just a little bit inferior to it and traveling through a little hole nearby is the zygomatico-facial nerve. These are both purely sensory to the outside area right around here. Now the next thing that's going to happen is we have a branch that heads anteriorly and is going to wind up being sensation for the cheek. And when you do clinical examination of the trigeminal nerve, you're generally going to check someone's forehead to see if their ophthalmic is intact, and you're going to check this area around the cheek to see if their maxillary is intact. And that branch is known as the infraorbital nerve. The infraorbital nerve travels through a cleft and winds up on the bottom part of the orbit, and that's going to be the inferior orbital fissure. Now from there it travels on the floor of the orbit and eventually enters the maxilla itself. And just before it exits, it travels through a little hole just right about here on the cheek. If you press hard enough, it hurts a whole lot. And no big surprise, the name of that hole is the infraorbital foramen. Now, that's simple enough. But one thing that's happening is that the infraorbital nerve also sends a bunch of branches off that are sensory to your teeth. Your superior alveolar nerves innervate the pulp area around your teeth. This is actually very important because your teeth have a lot of feedback. That's why you don't wind up breaking your teeth when you are eating, is because you get a lot of sensory input about how much pressure is being exerted on each tooth. And here we've got a branch that heads down to the posterior aspect of the maxilla, actually pierces the bone through its own little opening there. And then once inside the orbit, another branch comes down, and just before it exits the infraorbital foramen, another branch comes down. These are all referred to as superior alveolar nerves, and they're all going to the teeth of the upper arcade or the maxilla. The one that's back here is the posterior superior alveolar. This one's the middle posterior alveolar, and this guy, I'm sure you're not surprised to hear, is the anterior superior alveolar. Now, in addition to the teeth, these guys are also innervating the maxillary sinus, and if you've had a sinus infection, you know just exactly how irritating this can be. And in fact, maxillary sinus infections will often make you feel as though your teeth are hurting. It's not because the teeth are in pain, it's because this packed, nasty sinus is aggravating the nerves that are traveling through it and tricking your brainstem into thinking the signal's coming from the teeth. But I digress. Oh, and they all form little arcades out here that go to each tooth along the upper arcade of the maxilla from the molars all the way forward to the incisors. Then the last branch that we're going to talk about, I have to clear a little room, so bye-bye inferior orbital fissure, is a branch that actually jumps into the nasal cavity. And this guy, let's draw him a little further out here, it's called the sphenopalatine nerve. And to get where he's going, he goes from the infratemporal fossa, which contains all of this, through a hole called the sphenopalatine foramen, which we are just going to abbreviate SP foramen. Now once there, this nerve travels into the nasal cavity, and it's going to supply your nasal septum and the lateral aspect of your nasal cavity, where the conchae and other structures are. So we have a septal branch of the sphenopalatine and a lateral nasal branch. Okay, so V2 is entirely sensory. The maxillary nerve's whole function is sensory to this middle part of the face. But just like V1, we've got some autonomics that are hanging out here too. There's a ganglion just hanging out near where the palatine nerves jump off of the maxillary nerve, and this guy is referred to, make sure I'm putting it someplace we won't miss it, the pterygopalatine ganglion. Now, pterygopalatine ganglion, for a medical neuroscience course, the main thing you care about is that this guy is going to send axons up the temporal branches, and from there, just like we saw before, it's going to jump onto the lacrimal branch of V1 to get to the lacrimal gland. That's pretty good. The other thing we care about regarding it is going to be how the preganglionics get here in the first place, and then some other targets that it has that have some clinical significance. So let's start by filling in a little something here. A little further back in the petrous portion of the temporal bone, we had a branch of cranial nerve 7 that traveled from the near where it enters the skull, the petrous temporal bone, called the greater petrosal nerve. And it travels through a bony structure called the pterygoid canal. I did not verify that my spelling's 100% perfect on these guys. In fact, I probably need a Y right here. In addition to these parasympathetics that are coming in, there's also some sympathetic fibers that are coming from the superior cervical ganglion. They travel through the pterygoid canal as well. Now these guys are known as the deep petrosal nerves, and I've discussed this in my autonomics of the head lecture, so don't obsess about this now. But what we do care about is that these postsynaptic parasympathetics are traveling alongside these presynaptic parasympathetics from 7, and these guys are collectively known as the nerve of the pterygoid canal. And even though it's a lot to keep track of, at least the nomenclature is somewhat sensible. So these presynaptic parasympathetics are running from the pterygoid canal, and they get here to the pterygopalatine ganglion, synapse, and send postganglionics to the lacrimal gland. Great. They also send postsynaptic parasympathetics to the palate, to the nasal cavity, and to maxillary sinus. And just like the lacrimal gland is a secretory gland, there are secretory glands scattered throughout the palate and the nasal cavity, and that's what these postsynaptic parasympathetics are going to. So these are the guys that cause your mucosa to swell up and secrete, are coming from that pterygopalatine ganglion right there. And along with them, these postsynaptic sympathetics are along for the ride, going to all the same places. And once they get there, their big job is to shut down blood supply. So parasympathetics make glands secrete by increasing their activity. Sympathetics shut that activity down mostly just by constricting precapillary sphincters and closing off the blood supply. Alright, that's it for cranial nerve V2, the second branch, the maxillary nerve, coming off the trigeminal, and we'll come back with our final branch, V3, the mandibular. Alright, welcome back, and we're here with the last branch of the trigeminal nerve, the mandibular branch, V3. Now, the mandibular branch exits the skull through the foramen ovale. And it heads down into the infratemporal fossa, which is basically the area medial to the jaw and deep to the zygomatic bone right there. Now, once it exits, it's going to have many sensory branches that jump off of it. So first off, we're going to put in one that goes posteriorly. And that's going to be the the auriculotemporal nerve. And it's heading out to the skin, just posterior to the ear, and a little bit covering the auricle right in there. The next branch is going to head forward to the cheek, and that's going to be the buccal branch. Now, this is important to note that this is the buccal branch of 5, meaning that it's sensory, and it's sensory to the inside of the cheek. There's a buccal branch of cranial nerve 7 as well, but it's motor to the buccinator, or the muscle of the cheek itself right there. Now, in addition to those guys, there's also a very small little branch that comes off and heads upwards, the foramen spinosum. And it's doing that alongside the middle meningeal artery. And this branch is the dural branch of 5. I should say the dural branch of the mandibular nerve. And this is a major sensory input from the dura mater. And the dura mater is an incredibly sensitive structure. Most of the cluster headaches, migraine headaches, and other sensory, really severe headaches that people encounter are not due to the brain and not always due to musculature, but actually due to the dura mater. So this is a major nerve for the treatment and understanding of headaches. Now, after that, we've got a few big sensory branches that are going down to structures of the jaw, both inside and outside the mouth. The first one is going to be a branch that goes inside the mouth, supplies the anterior 2/3 of the tongue. And this is the lingual nerve. So the lingual nerve is supplying the inside of the mouth, the anterior 2/3 of the tongue, and the other branch that comes up nearby and runs parallel with it for a fairly decent way is called the inferior alveolar nerve. Now, the inferior alveolar nerve, like its name suggests, supplies the teeth. and these are the teeth of the mandible, the lower arcade. To get there, it actually goes through a small hole in the medial aspect of the mandible, and this is the mandibular foramen. Draw that over here. So the mandibular foramen is the hole that the inferior nerve uses to enter the mandible, and at the very front of the chin it exits and supplies the chin itself, and this is referred to as the mental nerve. So think deep thoughts, rest your fist on your chin, and it exits through, no surprise, the mental foramen. So that is the sensory function of cranial nerve V3, the mandibular branch. No big deal there. Now it gets to the interesting stuff. Cranial nerve V3 is the only one that has some motor activity associated with it. And what are we going to use? And the motor activity associated with it, we're going to draw in red here. Actually, we already have the arteries, so let's not do red. Is coming from the brainstem and is referred to as SVE. Now, I'm not a big fan of this term, special visceral efferent, but that's what a lot of the textbooks have dubbed it. These muscles, all SVE muscles and nerves, originate from the pharyngeal arches, and the first pharyngeal arch forms the maxilla, the mandible, and the muscles that are associated with it. And V3, the mandibular nerve, is the branch that innervates all these muscles. And these muscles attach to the jaw and move it, and are therefore known as the muscles of mastication, the muscles that allow us to eat. So it travels along with the trigeminal nerve, exits along with the mandibular, and right about here, where these guys are branching away from each other, it has a few important branches. First and foremost, it goes to the muscles of mastication. So let's name those. Branch to temporalis, a branch to the masseter, the big muscle on the outside of the jaw. So when you clench your jaw, the masseter is the one that bulges out, although the temporalis up here, pretty pronounced as well. And then you've got two muscles on the medial aspect of the jaw that help move it from side to side and protrude the jaw. And these are the branches to the medial and lateral pterygoid muscles. Now, there may be multiple branches heading to each of these muscles, but they're all fairly tightly confined within the infratemporal fossa, just medial to the jaw. So any damage in that area could potentially interfere with someone's ability to move their jaw and eat. Now we're going to draw in a couple small branches. There's a little tiny branch that goes towards the middle ear and innervates a scrawny little muscle that inserts on the malleus in the middle ear. And this is called the tensor tympani muscle. And it basically stops the malleus from moving so violently that it ruptures or causes any damage to the membrane that separates the middle ear from the outside ear, tympanic membrane. That would be nice if that was all, but we're not that lucky. There's also a branch that sticks to the inferior alveolar nerve all the way down and only jumps off just before the mandibular foramen. And this nerve travels to two muscles on the underside of our mouth, the anterior belly of the digastric, and just superior to that, running transversely across the floor of the jaw, is the mylohyoid muscle. So the mylohyoid muscle and anterior belly of the digastric. Anterior belly of the digastric comes from the first pharyngeal arch and therefore is innervated by V3. The posterior belly digastric comes from the second arch and is therefore innervated by the facial nerve, which we'll see in a bit. Now this nerve has the very sensible name of the nerve to the mylohyoid, and that's its name. Anterior belly digastric gets no love in this case. But that is how those nerves get there. And that takes care of most of those muscles, except for one tiny little guy that we haven't mentioned yet. And we're going to draw him in just back here. And that's a nerve that travels inside the posterior aspect of the nasal cavity in the nasopharynx and is the tensor, putting the two tensors together, veli palatini. So if it's a tensor, it's innervated by V3. Alright, so we've covered the GSA, sensory, the SVE, branchial or pharyngeomotor aspects of cranial nerve V3, mandibular branch. Wish that was all. But guess what? We've also got a parasympathetic ganglion hanging out associated with V3. And this guy goes by the nice short name of the otic ganglion. So otic ganglion contains postsynaptic parasympathetic fibers that are going to the parotid gland, our major salivary gland, right here on the side of the jaw. So from cranial nerve 9, we have the lesser petrosal nerve. One of the many things cranial nerve 9 does. And that lesser petrosal nerve travels through the petrous temporal bone, jumps down through the foraminal valley, and then synapses with cell bodies in the otic ganglion. From there, these otic ganglion postsynaptic parasympathetics descend along with V3, branch off at the auriculotemporal, and travel along the auriculotemporal nerve to get to its target, the parotid gland. And if these get this innervation gets compromised, you can wind up with a dry mouth because the parotid gland is no longer secreting watery saliva into the oral cavity. And quick note, this little branching causes a loop to form around the middle meningeal artery as it descends towards the foramen spinosum, and that's one way you can identify the auriculotemporal nerve in the cadaver is by looking for that loop going through the middle meningeal artery. All right, doing good? Glad you asked, or glad I asked, because we got one more thing to worry about. Yet another ganglion is hanging out in association with the mandibular nerve. This guy is just underneath the jaw, so right around here, and is referred to, thankfully, as the submandibular ganglion. Now what's going on here is we've got branches not of cranial nerve 9, but of cranial nerve 7. Last time we saw cranial nerve 7, it was giving off the greater petrosal nerve, which synapsed with the pterygopalatine ganglion to supply the lacrimal gland, and the mucosa of the nasal cavity, maxillary sinus, and so on. Cranial nerve 7 also has a branch called the chorda tympani that descends through the petrous portion of the temporal bone after it peels off of 7, and it runs through the infratemporal fossa on its own until it gets to the lingual nerve, at which point it joins the lingual nerve, and its axons run on the lingual nerve surface, and that's what allows it to approach the submandibular ganglion. So here's the chorda tympani, and it gets its name from the fact that it's a little tiny string of a nerve running through the middle ear. So the facial nerve actually goes through the middle ear, dives down the facial canal, gives off the chorda tympani, which kind of runs back through the middle ear before exiting the skull. And just for kicks, it exits the skull at a tiny little cleft of bone called the petrotympanic fissure. And if you're feeling really gutsy, go try to find that on a skull. It is there, but it's a really tiny little cleft of bone in the petrous temporal bone right there. Now from the submandibular ganglion, it's the presynaptic fibers from the chorda tympani synapse, postsynaptic parasympathetics from the submandibular ganglion, just jump on branches of the lingual and get to their target. And their target are two salivary glands in the floor of the mouth. The submandibular and the sublingual salivary glands. So interruption of these fibers can also cause dry mouth, although the parotid is hugely responsible for the watery saliva when our mouth waters and we're getting ready to eat. So that's the parasympathetics. And once again, I'd like to tell you we're all done and we can move on, but there's one last thing the chorda tympani is doing. We already talked about how the lingual nerve is sensory to the anterior 2/3 of the tongue. And what that means is if I bite my tongue, if I burn my tongue, those impulses are traveling back to the central nervous system on the lingual nerve, V3, and back to the brainstem nuclei of the trigeminal system. Taste, and I don't know how to say it other than that's just how it is, taste is different. Taste gets back by following a different branch. Not a different branch, but a different set of axons. Taste sensation doesn't follow the trigeminal from the anterior 2/3 of the tongue. Instead, it's going to follow axons that hop on the chorda tympani. I'm going to have to draw this in a little darker. And travel back with 7. So these taste fibers are actually going to be associated with the lingual nerve as well, but they're really branches of 7, and we're going to talk a little more about these when we get to cranial nerve 7. What I want you to know about them right now is they're a different modality altogether, and this isn't going to color in too nicely, but very pale pink here. These fibers are taste fibers, and they are known as special visceral afferents. Special visceral afferents projected to the solitary nucleus of the medulla, particularly its rostral part called the gustatory nucleus. And because they have a different function, they're going to wind up in a different nucleus inside the brainstem. All right, now I'm finally done talking about V3. I've got nothing more to add to this. The last part of this we'll be looking into what happens from all the impulses from the ophthalmic, the maxillary, and the mandibular, and how they make it back into the brainstem and what happens there. All right, now we're back with the final bit about the trigeminal nerve. And we've covered all of its peripheral branches. Now we're going to see how it all intersects in the central nervous system. So, from the forehead, we had V1. From the cheek and most of the nasal area, we had V2. And from the mandible and the lower part of the jaw, we had V3. It's impossible to overstate the importance of knowing the little bony exits these guys have from the skull. So always review V1 through superior orbital fissure, V2 through foramen rotundum, and V3 through the foramen ovale. Now these guys, what the heck, we'll draw the cavernous sinus in there as well, just for fun. Travel back and all intersect at the big trigeminal ganglion. As we said in the very first part, this contains pseudo-unipolar cell bodies that are the sensory cell bodies associated with all these sensory functions. The main trunk of the trigeminal nerve extends posteriorly from that to get to the brainstem. Now here I'm going to draw this out quite a bit more elongated than it should be, just to make things a little bit easier to spot later on. And we're going to go back to the central nervous system. The trigeminal nerve exits or you could look at it as entering the central nervous system through the pons. And superior to the pons, we've got the midbrain, and I'm drawing in the two big cerebral peduncles right there. Below the pons, inferior to it, we've got the medulla, and that just pinches off to become the spinal cord thereafter. I'm drawing the little midline structured there. And so pons right here, cerebral peduncles extending up on either side of it, and then the cortex and thalamus are going to be located just superior to there. So we won't bother with the cortex, but we draw the thalamus in on each side. These little golf balls hanging out on top of the cerebral peduncles there. So the trigeminal nerve enters at the pons, and what makes the central wiring of the trigeminal nerve really interesting is it's got three separate nuclei that it projects to. The first one is located right here in the pons, and that is where fine touch, proprioception, fine touch and discriminative touch and vibration sense wind up. And this guy is called the chief sensory nucleus of the trigeminal, or chief trigeminal nucleus. If you see chief or main, it's probably referring to this guy. In addition to that, there's a mesencephalic trigeminal nucleus. This is where proprioceptive inputs go. So mesencephalon, other words, midbrain, and that's where that nucleus is. And last, certainly not least, is trigeminal nucleus that extends all the way down through the medulla, pretty much right to the top of the spinal cord, where it's confluent with the dorsal horn of the spinal cord. This elongated guy is called the spinal trigeminal nucleus. All right, now, if you've reviewed the lectures I did and posted on somatosensory in the body, you'll notice that, or you'll remember that vibration, proprioception, and fine touch travel in one system, and pain, temperature travel in a different system. And it's actually the same in the head, same layout. Fine touch and vibration, chief sensory. We split that a little bit and go to the mesencephalic for proprioception, and the spinal trigeminal is where all painful and temperature stimuli from the face wind up projecting. So these guys travel in here and are going to synapse on cells in each one of those nuclei. And the spinal trigeminal nucleus is so long that as these guys travel in and synapse, they actually form a distinct tract inside the brainstem, and this is called spinal trigeminal tract. Now, if you remember what happened in the body, what happens after we synapse, we cross to the other side. Not in the John Edwards Ouija board kind of way, but in the physical decussation way right here. And from here, the decussation of this guy and this guy are going to form a tract that heads up to the thalamus, and this guy is going to be called the trigeminal lemniscus. And if you remember the medial lemniscus from the body, no big surprise, it's carrying the same material, vibration and fine touch from the head, trigeminal lemniscus, vibration, fine touch, proprioception from the body is going through the medial lemniscus. And this guy is projecting up to the thalamus, and it's going to a nucleus there. It's called the VPM, posterior medial nucleus of the thalamus. And just for kicks, we'll draw in the VPL nucleus. That's where sensory information from the rest of the body is projecting. So there's a pretty close correlation between these guys. Now, I haven't drawn in the mesencephalic yet. There's a reason. I'll get to that very shortly. What's happening with the spino-trigeminal nucleus is analogous to what happens in the anterolateral system or the spinal thalamic tract of the body. It synapses with nuclei at all these levels, and they cross over gradually at each level and can kind of come together to form a tract that ascends to the same place in the thalamus, the VPM. And this guy goes by a slightly different name, but if you remember, the anterolateral system projecting to the thalamus was called the spinothalamic. No big shock here. This is the trigeminal thalamic tract. And once these guys have all reached their the third order neurons here in the VPM nucleus of the thalamus, they project up to the cerebral cortex, and in particular the somatosensory cortex on the post-central gyrus, kind of on the lateral side where facial sensation is kind of involved, and we become aware of what's going on with our face, whether it's painful, whether it's hot, whether something's poking it. All of that's happening in the cortex. Now, the one guy I left out right here, mesencephalic trigeminal nucleus, is a bit of an oddball, and I left it out because it's closely tied in function to one more trigeminal nucleus. We've talked about SVE, this visceral efferents, that are actually providing innervation to the muscles of mastication. Because it's a different function, there has to be a different nucleus for that. And that nucleus is hanging out right around here. And that guy goes by the very sensible name of the trigeminal motor nucleus. Sometimes called the motor nucleus of 5. Same thing. And those motor axons are going to project from the trigeminal motor nucleus out along the trigeminal nerve, through the trigeminal ganglion, peel off on to V3, and go to all the muscles of mastication, all the tensors, and the mylohyoid and the anterior belly of the digastric down here. The mesencephalic is where we sense proprioception. And proprioception in the head involves the teeth a little bit, but the major input is from the jaw, from the temporomandibular joint. And this is the guy that lets you know exactly where your jaw is in space, and is the reason we don't smash our teeth every time we take a bite off a gobstopper or some other hard candy. So what's going on with this guy, I'm going to draw these in just a slightly different shade of green. I don't know if it's going to show up. Looks about the same. Yeah. So we'll just draw these in as a separate little branch, even though they're just part of the trigeminal. Ascends with, and it's running out, so much for that idea. It ascends just as part of V3, goes to the trigeminal ganglion, but does not have a cell body there. Its cell bodies are still way back in here, and that's pseudo-unipolar cell body related to proprioception from V3, and it's going to send some of its axons right down here to the trigeminal motor nucleus so that it can have a quick reflex. So if I'm sensing a lot of pressure, I'm biting really hard down on a piece of jerky and it tears free, my teeth don't click together and smash, this signals my jaw to loosen up and not have any violent collisions. Now, in addition to that, there's some fibers that are going to peel off up to the VPM nucleus of the thalamus, and make sure we're aware of what's going on with that. But proprioception and motor are pretty closely tied together in the trigeminal system. All right, I think that's pretty much all I've got to offer for this. We'll pick up next with cranial nerve 7, which functionally is most closely aligned with 5. And thereafter, we'll talk about other cranial nerves as their modalities make a little more sense. Thank you very much, and I'll see you in the next video.